So the addition of selective internal radiation was the scope of a major clinical trial that was actually the consolidation of many other trials. And what they did in that clinical trial was to add selective internal radiation to the frontline therapy that at that time it was chosen as the control arm to be a FOLFOX Avastin regimen. And the study was done in order to try to see if frontline treatment of non-resectable disease in the liver would change the survival of the patients. The design of that trial, which was the SIRFLOX and the FOXFIRE studies, was done by adjusting a little bit the doses of the experimental arm. The investigators were concerned that there could be a problem of giving the targeted agents, such as bevacizumab, with the selective internal radiation, and they withheld that biologic until after the 4th cycle. Furthermore, they were concerned that radiation may radiosensitize the liver too much, and they decreased the doses of the oxaliplatin on the FOLFOX regimen in the experimental arm to a dose level -1 of 65, and then re-escalated the doses again after a few cycles of treatment. And they intended to treat the patients concomitantly within the first cycle or so of the treatment of chemotherapy with the selective internal radiation. The control arm was standard FOLFOX bevacizumab type of regimen, and the patients were treated until progression. The primary objectives of the studies individually were progression-free survival, and the joint studies of all the studies that were done globally was overall survival. There were two other caveats of the design of the study. They allowed for patients to be treated even if their disease was not liver limited, meaning that patients that could have metastatic disease outside of the liver were eligible to go on the study just with liver dominance, but the progression-free survival was taken not on the liver only, but the progression of any site of disease. So that, I think, that it could have confused us on the analysis of the data, because we decreased the doses quite a bit of the systemic chemotherapy, held the biologic probably until the time when the first scans were done, and by then we were calling progression of the disease, even if it was outside of the liver, that was the experimental side. So the design, I find it a little bit flawed, because we would have liked to see a design that would have allowed for the patients to be treated with much more similar chemotherapy and not dose-reduced, non-biologic based chemotherapy, and then subsequently to take liver-only disease, because the intervention was being done only in the liver. The final results of the SIRFLOX and the FOXFIRE studies were disappointing, because they did show that the progression-free survival and overall survival of the population that was treated in the study was not affected. So it is considered to be a negative study. Again, with the caveats that the progression-free survival could have been influenced by extrahepatic disease that showed progression, and then also even the overall survival by the possibility of the chemotherapy being insufficient in the initial stages of the treatment of the disease. Probably the most impressive part of the data that we could get nowadays of the studies with selective internal radiation with microspheres is that the sightness appeared to have, again, a prognostic and predictive factor. So the sightness was prognostic in the sense that the patients with right-sided tumors having a worst overall survival, but the predictive factor was opposite of everything that we have seen ever. The predictive factor that we have talked earlier is that every tumor that we have intervened on the left side does better with our experimental treatments. If we use a biologic, such as an EGFR inhibitor or a VEGF inhibitor on the left side, those patients are going to face a better prognosis. In the selective internal radiation studies, in the SIRFLOX and the FOXFIRE studies, the patients on the right side did better than the patients on the left, to the right side. The right side of the colon had survivals that have never passed in most of our clinical studies, the 20-month survival. With the addition of selective internal radiation, we've seen that the numbers with the patients being treated, and again, including even some patients with extrahepatic disease, may have crossed the 22-month survival. Now, bear in mind, and more impressive to this data, is that this is an unselected population of all comers and not only KRAS wild type. In the wild type studies, the patients with right side of the colon had a survival that was, again, less than 20 months. Here we have a population that may have included a lot of patients with mutated tumors that was going to over 22-month survival. So it is a very impressive data in that subgroup analysis.